It's a real pleasure to introduce Gregory Roth. He's associate professor in the cardiology division at the University of Washington and also at the Institute for Health Metrics and Evaluation at UW. His research is focused on global cardiovascular health surveillance, population health, and quality of care and outcomes for cardiovascular diseases. He earned both his bachelor's degree and his MD from Brown as a PLME, and then trained in internal medicine and cardiovascular diseases at the University of Washington. He's an attending cardiologist at the Harborview Medical Center in Seattle. And it's a real pleasure to welcome Greg back to Brown virtually. And we're really looking forward to learning more about disease modeling for this pandemic. Take it away.
Thank you. Can you see my title slide okay?
Yep.
Great. Well, it's a real pleasure to speak with all of you today. As you mentioned, I spent my formative years, almost a decade in Providence at Brown, and I was able to return a couple years ago for a reunion, brought my kids back. I love Providence and I love Brown, and it's just a nice opportunity to share with all of you some of the work that I've been doing, which has really taken an interesting turn over the last couple months. I'm going to go pretty fast and try and leave some room for questions at the end, so I look forward to those as well. As you mentioned, no conflicts of interest, and here are my research funders. So the brief outline of what I'm going to be speaking about today is the Global Burden of Disease Study, which is a tool for measuring health around the world using data science techniques, and my own work within that, measuring cardiovascular disease in populations. And then I'm going to talk quite a bit about how we've moved into this space of forecasting COVID-19 and healthcare utilization due to SARS-CoV-2, as well as then finishing up by talking a little bit about the cardiovascular complications of COVID-19, the little that we might know about it at this point, and how that's affected my clinical practice, and then some questions. So the Global Burden of Disease Study is coordinated from the Institute for Health Metrics and Evaluation, where I do my research here at the University of Washington, and is now in its third decade. It is a global collaborative research program that works to estimate over 350 different diseases, injuries, and over 80 risk factors for every single country in the world. We produce a time series of estimates from 1990 forward. We're about to release the new update through 2019. It's a massive integrator of thousands and thousands of data sources, and we produce standard measures of population health like incidence and prevalence and death rates, but also what we call summary measures like disability-adjusted life years and healthy life expectancy, and some of the information that decision makers really need to manage the large-scale health decisions that are made within countries, ministries of health, and within health systems as well. It's really key, and you'll see why this comes up when we start talking about COVID-19, that it's not a traditional study in the sense that it runs to completion and ends, but really it's an ongoing collaborative effort with annual updates, and those are updates both with new data and updates with new methods. And so our estimates change from cycle to cycle as we try and evolve to improve the way we do it, as well as what we include as inputs into the study. You can see a map of our collaborator network. We have now over 5,000 individuals, research scientists, government officials, clinicians, epidemiologists all over the world collaborating on the study. And every year we produce what we call capstone set of articles in a dedicated issue of The Lancet, as well as many hundreds of other papers coming out of the study. I want to give you a sense of the sort of high-level approach that we use in terms of methods in this study. And so the first step is that we are really trying to bring together all of the population health data in the whole world. This means vital records like death certificates, surveys, cohorts, randomized trials, registries, also what is rapidly becoming the world's largest collection of administrative health records, so electronic health records from about 50 different countries, even satellite data to look at things like air pollution and a range of other risks. All of that is publicly searchable through what we call the Global Health Data Exchange, or the GHDX. You can see a snapshot of it there. You can find it on the web, and you can find every single input data source that goes into the study. The very high level sort of outline of the methods is collect all the available population health data, use a wide range of geospatial epidemiologic modeling methods to produce consistent estimates, and then report those estimates with uncertainty, because we also produce estimates not just where we have data, but for all locations. And in a lot of locations, we're estimating by borrowing strength over time and across space, because we don't have data for every risk and every disease in every location. You can see a picture of two of our tools here. One, this happens to be our stroke model. So this is all of the data on the incidence of stroke in the world. And we're fitting sort of a global average curve to that. That's age on the x-axis and stroke incidence on the y-axis. Each of those little gray cross marks are a single data source or study. And then we drill down in increasing levels of granularity to all of the specific locations in the world. On the very right there, you see an ensemble model software tool that we've designed to help smooth out death data. This is calcific aortic valve disease in the country Colombia. And so we spend a lot of time trying to make sure that something like death records are actually consistent and comparable across countries and different systems, across different iterations of the ICD coding system, and to try and find bias and correct bias to produce plausible results. So that all feeds into the global burden of disease study, and I'll show you what the results look like at a high level. This is a tree map, which is just a fancy way of saying a squared off pie chart. This represents all of the global deaths that occurred in the year 2017, and we've divided it up into about 20 high level categories. You can see CVD in the upper left-hand corner is the work that my team contributes to the study. But it's important to recognize that actually the work we do is not really one research team, but many hundreds of research teams using shared methods and techniques that are working in parallel. And so let me unmask sort of the underlying complexity of global death patterns, which looks like this. And you can see, for example, that cardiovascular disease has now been carved up into ischemic or coronary heart disease. Stroke has been carved up into intracerebral strokes, ischemic strokes, subarachnoid strokes. All of these disease categories are actually estimated at that very specific clinically relevant level. And so this shows us that cardiovascular disease was 33% of global disease deaths in 2017, but ischemic heart disease was 16% and stroke was 12%. So we actually have an online visualization tool. You can search GBD compare online, and you can play around with this. You can adjust this over time. You can drill down into even more specific disease detail. And so that's one of the messages I have here, is that to get global health right, you actually have to get each specific disease right. And we spend a lot of time thinking about what conditions go into each of these buckets. And so we spend a lot of time working with researchers around the world to understand how case definitions for disease might map to sort of the standardized hierarchy of diseases that we use for the global burden of disease study. This is a picture of our work on cardiovascular disease, just for an example. So while we estimate just under 500 million prevalent cases of cardiovascular disease globally, ranging somewhere between about 470 and just over 500 million, what we're actually doing is summing up all of these specific diseases that fit these very specific case definitions. So for ischemic or coronary heart disease, we're looking separately at acute coronary syndrome, stable angina, ischemic cardiomyopathy. For peripheral arterial disease, we're looking broadly for studies that have identified cases where the ankle brachial index is less than 0.9. For atrial fibrillation, we're looking for studies that have actually captured this on ECG. For degenerative mitral valve disease, we're looking for studies that have allowed us to estimate more than moderate severity mitral regurgitation based on Doppler signals on echo. So we spend a lot of time working back and forth between the clinical details, the epidemiologic methods, and then the data science that allows us to connect it together. You can see here that ischemic heart disease cases just over 120 million globally, but of course it depends on the case, and if you think about subclinical atherosclerosis, the number would be many, many times larger than that. So here's another way of looking at the high-level results of the global burden of disease study, and what we've done here is we've taken all the deaths in the world, and you can see deaths in females on the left side of what I call sort of a butterfly diagram, and on the right for males, On the x-axis, you see the counts of deaths, and you see age on the y-axis, starting neonatal at the bottom and then going all the way to 95 plus at the top. So just a couple take-home messages. So you can see these categories of different disease states and causes of death color-coded. Early in life, you see that neonatal deaths and childhood infections and then younger adult traumas in green, skewed to the right side, meaning more for males, are a predominant cause of death. But as people move beyond the age of 40 and 50, you see this rapid increase in cardiovascular deaths, in malignancies. And then at the oldest ages, you can see cardiovascular disease and dementia causing larger numbers of deaths in females. So this is just one way of trying to get sort of a snapshot view and understand the interaction between sex, age, and the cause of mortality globally. And then within our study, of course, it's particularly interesting to see how this changes over time. And this is another way of looking at that over time. So here, we've taken all of the deaths in the world and we've binned them into these major categories. You can see them color-coded on the bottom. And each of these views is from 1980 to 2017 on the x-axis, with the total years of life lost on the y-axis. So years of life lost is a really interesting metric. It's not a death rate, but it essentially takes your death rate and weights it by how old you were when you died, meaning that those who die at younger ages contribute more years of life lost compared to those who die at the oldest ages. The facets here are what we call SDI, or Sociodemographic Index. And the Sociodemographic Index essentially is a summary measure of income, fertility rates, and education. So it's a really robust proximal measure of socioeconomic status. And so in the very left-hand pane, you can see that the causes of death due to respiratory infections, maternal and neonatal disorders, and enteric infections, the major causes in those low SDI places. So most of this is in sub-Saharan Africa and a few places in Asia have plummeted over the last 30 years. Down at the bottom, you can actually see spikes in yellow from self-harm and interpersonal violence in that area. So the largest of those spikes, just to give you a sense of scale, is the mortality associated to the violence in Rwanda in the mid-1990s. You can also see in the middle SDI, capturing mostly from Indonesia, a gray spike for unintentional injuries related to the tsunami that swept through the Indian Ocean and caused about 250,000 deaths in the mid-2000s. And so that gives you a sense of how these shocks to mortality are actually quite large compared to just the total number of deaths globally. And I think that's you'll see relevant to COVID-19, which of course is going to turn out to be a very large shock on mortality as well. I'll just flag one last thing, which is that all of the high-income countries in the world are in that rightmost high SDI pane, and you can see that cardiovascular diseases have actually declined. That's that blue line, while neoplasms have increased. But in the last couple of years, alarmingly, we're beginning to see, after about 30 years of a decline in cardiovascular deaths in the high-income world, that they themselves are also increasing. And so for the first time ever, this massive win for public health, which was a decline in cardiovascular mortality, is probably over and starting to reverse. And that's actually quite concerning and a question of how that'll interact with what's going on in the world today. We're not just interested, though, at this very high level global picture, and we're not even interested in just what's going on in countries. We really want to produce comparable and consistent estimates that are subnational as well. If you imagine that you were running a Ministry of Health in a country or in charge of a very large health system, it's that much more granular geographic estimation that's going to be really important. And so you can see here, this is disability adjusted life years for cardiovascular disease, that we actually produce them for US states, subnationally in India, in China, in Russia, in South Africa, in many, many countries. We work directly with countries. We spend a lot of time working with ministries of health, sharing data and collaborating to produce these measures that are actually used within countries to drive policy. One of the really gratifying parts of this work is to actually see this changing the choices that decision makers make at a high level, and that's something that's happened quite a bit with the Global Burden of Disease study. The US, however, is a much more complicated place when it comes to health policy. So we have reported here, this is coronary heart disease deaths in the US at the county level. you can see that if you just look at the country overall, you miss patterns. If you just look at the states overall, you miss patterns as well. So Oklahoma, which tends to fare quite poorly when we look at cardiovascular disease in the US, turns out to be quite a heterogeneous place. The same is true of Arkansas, and it's actually true of all states. And it turns out that the heterogeneity when it comes to cardiovascular disease burden continues down and down to the local level. And we see really amazing changes, even when you just go from, let's say one highway exit to the next. I think this is something that a lot of us recognize. We certainly see it here in Seattle. I know you see it there when you drive from exit to exit on I-95 in Providence. And the question is, are we connecting that to the underlying disease that's affecting populations in smaller areas? And the answer is we're starting to, but it's been a challenge. One of the areas where I have a lot of interest is in what's sometimes called hotspotting. This has been done for cardiovascular, this has been done for infectious diseases traditionally. It's been done a little bit for cancer clusters, but we're starting to do it for cardiovascular disease. The impact of community-based interventions when you test them really depends on how much disease is in the population. And so one of the things we've started to do is thinking about locating our studies in places where we'll get an early signal on whether interventions are effective, because we've actually found places where event rates tick over at a much higher speed. And that's really important for designing studies that actually tell us what we should be doing about population health. However, it's also really important when we look at health disparities. It turns out that if you're going to do something not just about disease on average, but really trying to shrink the disparities that are increasing, especially in the US, you really have to find where those disparities are. So here's some work that we did in Minneapolis and also in Seattle to really go beyond counties to the zip code level or the census tract level, and to start to try and tease apart some of the risk factor variation that really, especially I'll tell you in Seattle, ranges from some of the wealthiest zip codes in the United States to some of the most impoverished. And so we want to try and bubble that up and surface that, and then also feed that back into how we design studies. And so the last thing I'll say about cardiovascular disease is that we're very interested in using all of this information we're generating to forecast what we think will happen in the future. And you will see why this set us up to think very quickly about what we could do for COVID-19. So obviously cardiovascular disease and COVID-19 are very different in some ways, mostly the pace of the illness, with cardiovascular disease predominantly driven by atherosclerosis and predominantly happening very, very slowly over many, many decades. So here's some work that we did forecasting what would happen if different risk factor targets were achieved. We did this for all regions of the world. This figure shows South Asia, and you can see that depending on your ability to control risk factors in populations, you can have cardiovascular disease that starts to go back up or levels off, or really plummets down to that dotted line, which was the 25% reduction goal that the World Health Organization and the UN committed to. And I will just tell you, not to anyone's surprise, will almost certainly fail to achieve. And so we're trying to think about how to use some of our approaches to forecasting to help people make maybe better decisions about what their targets should be. It turns out that when people set these kind of long-term strategic goals, oftentimes there's a lot of things that drive their choices, and it's not necessarily what's achievable or what the evidence suggests is a reasonable target. And so we want to try and make that a more informed process, and that actually turns out to be, again, relevant to COVID-19. So let me pivot now to tell you about the work that's been going on over the last couple months here at IHME to try and get a handle on the pandemic that we're all dealing with. And so forecasting COVID-19 was actually initially a response to our own health system, UW-Medicine here in Seattle, because we were facing the first surge, and there were a lot of questions, understandably, as I'm sure you faced in Rhode Island, and I know everyone has faced, about what we should expect, what the demand would be on health systems, and what the demand would be in particular for ICU beds and ventilators. It turned out that as we got into this space, the demand for this work really exploded, and we found ourselves rapidly trying to expand this to try and provide a tool really to help decision makers in the US and then much more broadly. And so here at IHME, we have about 500 people at the Institute, and we rapidly started pulling people off of research projects calling funders, finding out if it would be okay to delay deliverables, and seeing what kind of resources we could bring to bear to this question. So we rapidly assembled a multidisciplinary team: epidemiologists, clinicians, mathematicians, computer scientists, public health researchers, data managers, on and on. Now, this gives you a good sense of the kind of multidisciplinary workforce that we have at the Institute to begin with. And it's one of the reasons why I think we've been able to fill this gap, is that we already had a lot of people working together on similar kinds of questions. Now, we've iterated through a number of different models, and that actually really is part of our culture here at IHME, and comes from a lot of our experience with things like the Global Burden of Disease study, that we don't necessarily stay attached to any one model or method, that we are rapidly trying to push estimates out and advance the methods of data science applied to these, public health and epidemiologic questions, while at the same time reporting the results of those models. So it's a little bit of a tricky balance there. We now are reporting what's, I think, being thought of as a 4th generation model here. And it's a hybrid model of looking at death rates, hospital utilization, and transmission of the coronavirus. And I'm going to walk you through it in detail. I'll apologize in advance. This might satisfy the wonkiest in the audience. But I am happy to answer questions as well afterwards. One of the features is that we update this pretty frequently, and so we actually have an update coming out later today. On May 13th, we added the countries that you see here, so we're starting to try and expand this to a global model. You can look at the results at this web link yourself, where they're publicly available, and you can look at all locations, including the US overall, Europe, new locations in Latin America and in Asia. I think we are rolling out, I believe, Russia later today as well. So it's a very, very complicated space, forecasting COVID-19 and coronavirus. And this just gives you a little sense of the data landscape that we've had to wade into, not just around death rates, but testing rates, social distancing measures, human mobility, hospitalization and length of stay, infection fatality rate, things like the age structure of populations, and the existing healthcare capacity. One of the hallmarks, of course, is that we do not have data on all of this in many locations. And so we spend a lot of time thinking about how do we leverage data that we might have in one location to other locations. And you can see how that sounds a little bit like what we do in the Global Burden of Disease study as well. I'm going to walk you through some of the steps in the model. Just collecting cases and deaths is a fairly large effort and requires a fair number of people. So we rely on a range of different sources. So like many of you, we've gone to Johns Hopkins, which has a really beautiful tool for aggregating deaths around the world and within countries. And we've relied on their work, though we've also started directly working, for example, in the US with state departments of health and a whole range of other sources. Here's an example in Germany where they've been reporting at the Robert Koch Institute, the subnational death rates, also similarly in France. And so we are looking at data from a range of different sources, and we're updating this continuously, essentially trying to find the most recent counts of death, and then a whole range of other deaths, data sources covering other issues as well. Now, you've also probably been aware that the death numbers swing around quite dramatically, and some of that is just due to reporting. We know that there'll be a holdup for a few days, and then a whole bunch of deaths will come out. There's variation in the reporting of death numbers for a whole host of reasons, and we're seeing that even more so outside of the United States. And so a fair amount of our work has just been to try and apply some kind of smoothing method that we think is plausible. We've been using an iterative moving average, and you can just get a snapshot there on the slide of what that looks like. That's really important because, of course, we know that in the population, the disease is not swinging wildly up and down like that, and that some of that needs to be smoothed out to make sense, and also to have a model that fits it in a plausible way. We also know that age patterns are one of the major drivers of the variation in mortality and morbidity related to this novel coronavirus. And so we've developed methods here. You can see to age standardize the death rates. This is just age standardizing everything to California. Obviously, you can age standardize to any structure you want, but what you want to make sure is that you're comparing apples to apples, and that's a step in the processing of the death data that we receive as well. We also know that the infection fatality rate is very, very important to understand from the perspective of age stratification. And so here's an example of one of our internal models in which you can see age on the x-axis and the log mortality, the log infection fatality rate on the y-axis. There are a number of sources that seem to be reliable, but of course you wouldn't want to make the mistake of assuming that the cases reported are the true infections. And so we've been sort of scouring the planet looking for places where we think we have some plausible capture on the true infection rate. We're seeing more of them. So I would say early on, the best one was probably the Diamond Princess, and continues to be one of the few places where we know that almost everyone got tested and probably almost everyone got exposed. There are communities around the world that have started doing widespread testing. The most recent one I saw was just over the weekend. Indiana has reported what looks like a very plausible population sampled approach to getting at infection and then linking that to fatality rates. And so that's a really important component of the model, and it's a part of the model that needs to be aware of age structure. To fit the death rate, we are currently using a sigmoid function. So here's the function for mathematicians, applied mathematicians, and other data scientists in the audience. We also have a preprint version of a publication, a manuscript about this, and you can find the link on our website, and you can read the methods section. It's on online. But initially what we did was actually fit a Gaussian model, which is a normal curve. And when we looked in Wuhan, we saw maybe not a perfect normal shaped curve to deaths, but not too far away. They came up very quickly and they came down very quickly. And one of the first things we started noticing as data came in from Italy and then Spain and then New York and other places with very large burden was that is not at all what was happening. And so we modified our approach. It's actually a mixture of different Gaussian models, and you can see that the shape of data in that middle figure on the slide is fit not by, in green, a normal curve, but a combination or ensemble of different Gaussian models that are actually moved forward and backwards in time and then merged to capture this sort of flat top to the death curve. There's also a covariate that tries to look at locations where the peak has already happened to try and better understand what the shape of the death curve is in relationship to when it actually finally peaks. So we're trying to fit a model that looks the same as the data in each location, but at the same time, this is generally thought of as a statistical model, a model that empirically observes data in the universe and tries to fit a mathematical function to it, has had to evolve, because it turns out that we're seeing quite complex patterns in the death rate as they accrue in different parts of the world. This death rate model has gone through a number of iterations, and at the same time, so is the hospital or healthcare utilization model, and that's the second component of this hybrid approach. So here on the left, you're seeing data on hospitalizations up through about the beginning of April in King and Snohomish counties. Those are the counties right around Seattle. You see this rapid rise, and then down at the bottom, ICU and invasive ventilator use. Similarly, we started getting data from places like Bolzano, so this is in Italy. And again, we're looking at trying to fit a model that looks at the ratio between deaths, hospitalizations, ICU bed use, and ventilators. And so that model is actually a simulation. It's separate from the death count model that I was just describing. And it really tries to back off from the number of deaths, how many hospitalizations we should expect, and then what proportion of those hospitalizations actually are going to critical care beds or going to ventilators. And the reason we started there was very pragmatic, which is that early on, really, there was no place where we could rely on case testing, because testing has been very heterogeneous and hadn't ramped up in a lot of places. And so we decided that while there certainly are biases in the reporting of death data, they were far smaller than the biases in reporting case data. It looks like it worked pretty well in terms of the planning that we did here in our own health system. So we rapidly started figuring out how many ventilators we had in different parts of the hospital, where we could create ICU beds if we needed them. And fortunately, we ended up, I think, flattening the curve relatively well in the Seattle area, and were able to manage the patients that came in, though we certainly did fill all of the ICU beds in some of the hospitals in the area. Obviously, it's looked very different depending on what city you're in. But this was one of the main drivers of why we even got into this space, was initially to answer these questions. We were asked locally by our own dean and our own health system leaders, how many ventilators did we think they were going to need?
Greg, this is Sharon. I've had a request if you could use the pointer.
Yep. Can you see that pointer there?
Yeah, yes.
Right there. Okay, I will do that. Thank you. So the third stage of the model actually was developed over the last 3 weeks or so and was rolled out about a week and a half ago, because as we went through the first wave of deaths that were occurring, and then really the first wave of cases, we started getting asked questions about how that various different covariates or drivers of the disease were going to affect transmission over a much longer period of time than this first initial surge. And so what we've done is developed a transmission model, a model that actually doesn't just look at deaths, doesn't just look at hospitalizations or critical care beds or ventilators, but looks at what may be going on in the community and tries to back calculate what we think is the actual number of cases and tries to predict what that might be in the future. So this is sometimes called an SEIR model. That's because this S is the susceptible population, the E is the exposed population, the I is the infected population. Here there are two I's because it gets transmitted, and then you have people who either die or remit. And so this kind of model is a traditional way of basically imagining people existing in various compartments, and as they all mix together, having the rates of each of these arrows inform what happens in the next box, and then also allows that to cycle back in sort of a loop. And so this allows us to estimate what we've been calling beta tau, but is what maybe some of you have heard of as R naught or RT, which is this question of how many infections each infected person then goes on to contribute to in the community. We have also looked for new ways to inform what might happen to this transmission factor as we move forward into the future. And we've started including a number of covariates. These include mobility, temperature, the availability of testing in populations, and population density. So we basically create a transmission model like this, but it is fit to the death curve that comes from that first model that I was describing that's looking at death cases. And so what that really is a transmission model that is bounded by the observed number of deaths that we see in the past, and then informed in the future by the kinds of drivers I've just described. And then as we estimate the number of deaths we expect in the future, we can also then estimate the number of cases that we're likely to see, and then calculate off of infection fatality rate, the relationship between those cases and deaths in the future. So I'm not going to go into more detail, though I'm happy to answer questions if they're within my capacity as a cardiologist to answer. But I will talk about mobility because I think it's particularly interesting and it's turning out to be quite informative. So early on, we were using the date that various social distancing policies were implemented to serve as drivers of our forecasts. And you can see in the lower half of this figure, this is actually a snapshot from our current public tool, in which, and I've selected Texas, though you could select any state, all of the different components of a social distancing policy are tagged by the date they started, and then in Texas, you can see the stay-at-home order actually ended. But we understood early on that the policy may be quite different from what actually happens, and we began to look for a way to link the policies to maybe some kind of more empiric observation of the policy's effect on populations. And we actually found this. We found this through mobility data. We actually found this from a range of different vendors. We've worked now with Google, Facebook, and then two organizations that also aggregate mobility data, Descartes Labs and SafeGraft. And they're all essentially doing the same thing with slightly different populations of mobile devices, which is calculating the average travel distance that each of us makes with our device in a given day, and then comparing that back to whatever was going on in early February or before that. And so you can see some examples. Here's Washington State here's Lombardia in Italy. They vary in ways that we've had to fix. And so actually we've built an ensemble model. So an ensemble model is just a fancy way of saying a model of other models. So you run many hundreds of models and then you weight them by something like out of sample predictive validity, where you hold out some data and you see how your model would have performed. We're basically trying to come up with a single metric of mobility where we are agnostic to the data source and we're agnostic to where it was collected. So we don't know anything about detailed travel of any individual, but we are able to construct what you see here, which is essentially a covariate of mobility averaging across all of these different sources. And because of that, we've started to be able to estimate the relationship between social distancing policies and mobility. And we then can feed this into the model to basically provide a little bit more robust direction for what we think might happen in the future. Now, we don't really know what's going to happen to mobility as we move forward, and we're not trying to predict things with a crystal ball that nobody can know. So we assume that sort of the benefits of social distancing will continue to exist as we move forward over the next couple months. But we've picked up on some interesting features. One of them is that people's mobility patterns changed well before social distancing policies went into effect, meaning that people actually started social distancing before their governor told them that they had to. And the other thing is that we've seen that people are starting to move around more. And you can see here in Texas, that's very true, that in early April, people started increasing their activity level. And so, what's the assumption here? The assumption is that people's average travel distance is actually somehow telling us something about their interaction, whether they're getting within 6 or 10 feet of each other and potentially leading to more transmission. We do not yet have any data on, how close people actually come to each other. This idea that a mobile device could actually tell you something quite granular. These organizations have not been willing to share that for privacy reasons, which I think I understand pretty well. But we're hoping that at the sort of aggregate population level, we can use this data, and we now have it from many, many countries around the world, to basically try and give us a better sense of what to expect in the future. The policy impact of these efforts has been pretty astounding. This picture probably speaks better than anything I can say. I don't think any of us expected this when we started designing a model to help our local health system decide how many ventilators they needed. But we've had close collaboration now with the White House, with FEMA, with the Defense Department, with many, many states, and increasingly globally with many countries. I think right now we're particularly focused on trying to produce estimates for sub-Saharan Africa, and work with countries where we think health resources are considerably more constrained, to try and understand what we can do there. But I would just say as a case study in the way that disease modeling may potentially impact policy, this is going to go down in the history books. And we are trying basically to do as much as we can to answer the questions that policymakers are getting forced to answer every day. And I mean, in some ways, this mirrors what we've been doing for a long time with the Global Burden of Disease study. I mean, our general approach is maybe very much what I learned at Brown about evidence-based medicine, which is that many, many decisions get made in the world that you would have thought were made with evidence and actually are not. And so if we can think about evidence-based public health, a term that's been thrown around for a number of years, if you can think about maybe precision public health, the idea that data science and other sciences can help us make better decisions, we're hoping that this turns out to be one of those cases. It is very complicated, and I'm fortunate to not be the person who has to be on the calls with some of these groups, but it's pretty complicated, and it speaks to the fact that also a lot of this work, as all science is done in a sort of soup of political issues, social issues, and it's something that we have to deal with and grapple with. In the end, what we try and do is do the best data science and the best epidemiology and modeling that we can, do this in as transparent a way as we can, and really bring an academic perspective to this, which is embrace peer review, embrace critique, and then adapt and iterate as fast as we can. We see this really as a process. That means sometimes we have to explain why our estimates change. And if you look at what public health decision makers in government often expect, it's not that you came up with a new model and then produced different estimates that you think are better. But that is still the right thing to do, and so it's what we continue to do. So lots of future work here at IHME around our COVID forecasting exercises. So we're incorporating, hopefully, strategies to look at the use of masks, contact tracing, and telework, thinking about mass transit, household size, humidity, air pollution, maybe providing multiple scenarios. A lot of this is constrained by resources and sort of how many people we have working on this. We've got about 100 people working on the COVID forecasting right now, but we have to let people sleep every now and then. And so, we are essentially trying to do as much as we can, driven really by the questions that we're getting from decision makers. We would like to expand this to all countries. I think we will. We'd like to expand this to all US counties, and I think we will do that as well. A lot of interesting questions that we have to grapple with. Can we measure distance between people instead of travel distance? How much can we learn about access to testing and quality of care and how that varies across locations? And will we get more information on comorbidity? So this is something of particular interest to me as a cardiologist and someone who both does research on cardiovascular disease and then sees patients in clinic with cardiovascular disease. So let me talk a little bit about cardiovascular disease and COVID-19. There's not too much to say yet because there's a lot more that we don't know. But I like this figure from Eduardo Marbon. They just published this, and the main take home here is while he's talking a little bit about the differences in viral versus host response and then sort of the long-term consequences of COVID-19, you can see that most of the things that in this figure have question marks after them. So are there cardiac manifestations of COVID-19? That is clear. Yes, there are. But there's very little data at this point to understand what they are. The mechanisms are very intriguing and probably include things like hypoxia, cytokine release, and cardiomyocyte direct infection. But again, there's not that much we know. I'll show you what I think are some of the most interesting sort of things I've teased out of the literature and from some of the consensus statements and our own work here. The first related to cardiovascular disease, as you've heard from other speakers and gets a lot of attention, is there are ACE2 receptors in a lot of organs in the body and certainly on cardiomyocytes. And so we know that there's very clear mechanism for how SARS-CoV-2, just like SARS-CoV-1, can get into cardiomyocytes and cause direct infection of the heart. We certainly saw from this paper that's gotten a lot of attention early in Wuhan that we see myocardial injury. And so this profound rise in troponins in those individuals who do worst, in this case stratified by individuals who die, in this figure really highlights the fact that the opportunity for cardiac injury is real. And we also know that people with pre-existing cardiovascular disease here in this paper, also out of a small cohort in China in the Wuhan area recently published, people with cardiovascular disease pre-existing their infection did the worst. And so, that's another feature that we know that those individuals who are sickest, are going to do the worst if they have severe complications related to this virus. But boy, does that just raise even more questions. And so, I think when we've had to deal with these patients at our hospital and across our health system, we've spent a lot of time thinking about the interaction between cytokine release syndrome and sort of the multi-system effects of septic shock and sepsis on myocardial function. This is something that we routinely see. I see this in the unit all the time, and I suspect you guys do too. It's very plausible, and there's good evidence to suggest that IL-6 is one of the main bad actors here. So here's from that same paper in the China region showing that IL-6 went up dramatically in those individuals who did the worst and didn't change that much among those individuals who survived. I'm going to add to this an older paper. This is 2004. Here, it's really intriguing as you dig into this literature, actually surprising how little work has been done in this area. But this is change in rat cardiomyocyte contraction with normal serum, and then they exposed it to whole serum from individuals who had active meningococcal sepsis. Then they essentially took out all the IL-6, and this is sort of a nice in vitro, in animal kind of model that suggests that there's at least good evidence here that IL-6 has a direct effect on cardiomyocyte capacity to contract. Here's a cardiac MRI recently reported from the Italian groups showing clear, diffuse stir sequence enhancement. They also showed late gadolinium enhancement associated with scarring. This is a completely inflamed left ventricle. The right ventricle, harder to see because it's thinner, but also inflamed. The pericardium, also inflamed. And so, it's very clear that we're seeing relatively small numbers, but, very real cases of isolated myocarditis or perimyocarditis, and that those cases are occurring in individuals who do not necessarily have significant respiratory symptoms. This individual presented with just myocarditis about a week after a very mild syndrome of respiratory disease that did not even lead to them seeking clinical care. There's another part that I just want to flag. It's getting relatively less attention, but I think it may be in the end more important, which is this question of coagulopathy. There have been some questions about stroke in young people, which my sense is we don't yet have enough data to know for sure about that. But we know in general that inflammation leads to coagulation. We know that there are changes in the intrinsic coagulation pathway, in platelet activation, in complement pathways, and in activation of vascular endothelium, in sepsis in general, in shock in general, in viral infections, even without obvious signs of sepsis. And here again from that cohort in Wuhan, clear changes in D-dimer levels. So D-dimer was so that's an odds ratio of 18 for mortality amongst those who had elevations in D-dimer level. And then this smaller cohort, but I think intriguing, from Klock et al. In Germany, looking at the cumulative incidence of thrombotic complications in patients in the ICU with COVID-19. So now at NYU, you can find this on clinicaltrials.org, are randomizing people to different anticoagulation strategies. A really important question, do people just get standard low molecular weight heparin like we would give them if they had critical illness in general? Should they get full anticoagulation doses of low molecular weight heparin? Should they get something else? I think the answer is to be determined, and probably needs to be determined by a clinical trial. So let me just summarize, and then I'm happy to take questions. Global health surveillance is changing rapidly, and I think we were watching it change over the last couple of years as we started sort of bringing data science to bear, as we started integrating clinical medicine, epidemiology, and data science in new ways. I think that we're going to see a huge acceleration in that work because of the attention focused on SARS-CoV-2 and COVID-19. But boy, do we still need better tools. And I think if anything, I'd like to leave you with the understanding that this is a work in progress, that there is a huge need for people to contribute to figuring out better ways to track disease, better ways to integrate the latest technologies and tools. And what I like to think about is cardiovascular disease as a slow pandemic, as opposed to SARS-CoV-2, a fast pandemic. These are both major challenges, as are a whole host of other global health risks. I hope some of you are interested in this field and hopefully will go on to contribute to it. In terms of the work that we're doing at IHME on COVID-19 forecasting, I'd like to leave you with the understanding that we're trying to build on really a scientific approach that we've developed around the global burden of disease study over a long time. That means global collaboration to share data broadly across different places in the world, rapid iterative applications of new methods, and then focusing on novel software tools. Oftentimes we have to build these ourselves, as well as increasingly large-scale cluster or cloud computing, which actually underpins almost everything that I've shown you today. In the end, I think we have to believe that good evidence can change policy for the better. That is the reason that I'm involved in this work, and it's the reason that a lot of us are. We have to figure out how to make sure that we emphasize reproducible data science. The work that we're doing in the cloud or on clusters This computer-based work has to be held to sort of the same standards as anything that we would be doing with pipettes in a wet laboratory or anywhere else. We need to think about how to make our methods as transparent as possible. And then I'd like us to really leave with this sense that policy-focused design means that we have to listen to the questions that have to be answered regularly by our policymakers and our decision makers, and that we have to be prepared to change what we do in terms of the design of our scientific studies to make sure that we're actually answering the most important questions and that we're doing it pretty quickly. So I want to thank everyone on the IHME COVID-19 forecasting team. Chris Murray and Steve Lim are really the two folks who've led this at our institution. It's been a privilege for me to get to be involved in it, but in many ways, they're people working night and day, every day on this, and it's been a really amazing experience for me professionally to be sort of in a place like this at a time like this. And then I want to thank my own lab, who's continuing to make sure that we've got estimates of cardiovascular disease for the world at the same time. And so also a number of different organizations around the world that we've collaborated with closely that we wouldn't be able to do this work without. And then my very last slide, I'll just say get involved if you can. If you're interested in becoming a collaborator in the Global Burden of Disease study, there's a call for collaborators. It's open right now. It's on our website. There's the link. And those of you even early in your careers who can bring expertise about a location in the world, a disease in the world, or some aspect of the work we do, I really encourage you to join. You'll be offered the opportunity to be co-authors on many of our papers. It's a really nice thing to do as you sort of move into this space. If you are, here I get to advertise as well. If you're looking for something to do full-time, we are currently hiring at IHME, both faculty, researchers, and staff. I have no interest in poaching any of your folks, Dean Elias, but feel free to send people my way if they're looking for something to do next. We have a post-bachelor fellowship, a really unique opportunity. We hire about 20 people right out of college every year for a 3-year program. You get an MPH, you get paid as a full-time employee at IHME, and you get to work full-time on our research teams. A really unique and I think amazing opportunity. We have a lot of online trainings and courses. We have a lot of in-person trainings and courses as well, but they're on hold at the moment. And we have our own master's in public health, master's in clinical research, and PhD programs in health metrics at IHME. And IHME this summer will be moving to the new Hans Rosling Center for Population Health at the University of Washington in Seattle. And so there's a picture of where we'll be located soon. Pretty exciting to bring all of the different strands of research around population health that are currently split across different places in Seattle all together in one facility. And so with that, I really thank you for your attention, and I'm very happy to take any questions.
Fantastic. Thank you very much. Great. Let's see. Are you, I would ask, are you using death certificate data? And can you comment on the accuracy of that?
So for the Global Burden of Disease study, we use death certificate data from every country in the world. In fact, we are really the world's greatest customers of death certificate data. And a huge amount of our work here is focused at improving the quality of vital registration systems, promoting the development of vital registration systems in countries where they don't currently exist, and trying to correct for biases in vital registration where we know there are certainly large biases. In the COVID-19 forecasting work, we have primarily been relying on case reporting of deaths, which has been happening through a range of different mechanisms. Some of them are death certificates for sure. Others are simply public health in various states, provinces, and countries reporting the number of deaths due to COVID-19. We've certainly seen that the case definition of COVID-19 deaths has changed a couple times in a couple different places. That is a good argument for making sure that you have a model that is updated regularly, because we've had to adapt to that. So the short answer is we have a very large stream of research around using vital registration and death certificates in sort of normal times at IHME. For the COVID-19 work, we are using the COVID-19 death reports that are coming to us from all over the world. And a lot of that is death certificates, but a lot of that is also public health sort of ascertainment methods that have sort of changed in this emergency setting. We are starting to look at all-cause death numbers as we move into countries where we know that even death reporting of COVID-19 is quite limited. So Ecuador is a good example where we're starting to try and look at these relationships between COVID-19 deaths and total death numbers, because we're actually starting to be worried that places like that, we may not have reliable COVID-19 death numbers at all.
So here's a question. Do you anticipate post-COVID chronic diseases among survivors of the virus, including those with cardiovascular disease?
Yeah, that is a great question and something that we've been giving a lot of thought to. The short answer that I obviously is the answer that we give for a lot of these questions is we don't know. The sort of intermediate term answer is probably some. We know a lot about the sequela of critical illness, and I won't get into that, but, from, the PTSD type syndromes that we see from people who have been on ventilators or critically ill and not on ventilators, we know that we're certainly going to see that amongst the patients who've been sickest. If we use SARS-CoV-1 as a benchmark, and it probably is sort of okay for some things, but not perfect, there were a whole range of long-term sequelae that I think my read of the literature is a lot of that was related to high-dose glucocorticoid therapy that was used in those patients. And so they saw avascular necrosis in large numbers of patients. They've actually seen long-term metabolomic changes and dyslipidemias. And so given the fact that while we are using high-dose glucocorticoids in some patients, it's not really one of the sort of first or second line therapies. I don't know. I suspect the pulmonary fibrosis is probably going to be related to people having what looks like a pretty complicated flavor of ARDS. Are we going to see other complications? Well, we're starting to see a very surprising and confusing inflammatory syndrome in children now that looks a lot like Kawasaki's with coronary aneurysms. So it's a good example of, don't think you know everything, because you'll get surprised again. And so I'm going to say yes, and probably more to come on that.
Another question, features in the models determine the shape of the outcomes. And can you comment on the potency of distancing, testing, tracing, masks, sheltering?
Yeah, so we have not yet reported what's actually, the intermediate results that are sitting inside the model on what the relationships are between these things, though we will. We just haven't had time to yet. So we certainly see a relationship between the mobility data and the social distancing policies. That's quite clear. That's also been reported in the New York Times that has done some nice analyses here. So I don't think that'll surprise anyone. I think the real question is what's going to happen when we turn off the social distancing policy. It's very unlikely that everyone goes back to where they were. And so we're already seeing an increase in mobility. Again, what's the relationship between mobility and disease rates? Well, that's what our forecasting model is currently telling you. But I think we're going to have to update this as we go, because we don't yet know where we're going to land in terms of mobility. And I think we're particularly concerned about what's going to happen as we start to see sort of these additional cluster epidemic outbreaks across the US in places where there's essentially no immunity and been very little exposure. We've looked at temperature. It looks like there is a real relationship with temperature, and that lower temperatures do lead to lower case rates. This is obviously sort of an epidemiologic analysis or a ecologic analysis, right? Because this is, using the data that we currently have across locations. I'll tell you, the effect is very, very small. And so while it's in the model, it's not having a big effect. And that leads us to think that summertime in the Northern Hemisphere, our prior is we're not going to anticipate that large changes in temperature are necessarily going to have big impacts on disease transmission. And then there's a lot of questions around masks, it looks like public masking policies may actually have a big impact, but I think it's hard to know yet.
Are there political impediments to data collection, and how does the IHME correct for these?
Well, that is a big question that I guess I will just interpret in a way that makes it easiest for me to answer. So, we are, as a research institute, reliant on the data collected by many other people around the world. And I guess I'll just say thank you if you are one of those persons, and to those out there who are doing the work of, actually ascertaining deaths and cases. None of this work would, exist without the investments that have been made in, public health organizations and institutions in government and outside government and health systems. It's actually, I think, sort of a reassuring story. We have found unbelievable openness to data sharing in this environment. We are working closely with the Chinese government, and they have been sharing extraordinarily detailed data with us from Wuhan and other places, built on long-term relationships we have working with them. And so if we can make that work in this setting, given the strains on all of these relationships, then I guess I would say maybe that's been one of the best things about this work, is we haven't actually seen the constraints that you might expect. And I will just say, I strongly believe that when political ties are strained, it is the job of scientists and physicians to build those bridges. And we need to do that while other sectors of the society, sometimes make it, make the relationships between countries more difficult. We need to build those bridges and work with our colleagues in those countries who are also trying to do the right thing and improve health.
How do you deal with privacy and confidentiality issues in global burden of disease in general and COVID-19 in particular?
Yeah, a really important question that continues to grow, I think, as people, sort of grapple with how we deal with, privacy in the mobile device, connected era. So the first thing I'll say is that, one of the benefits of, the Institute being based at a large state public research university is that we have all the transparency that comes and is required by us, working through the University of Washington's IRB, being, state of Washington employees, being academics and physicians who have to, meet a pretty high bar compared to what goes on in, let's say, industry or other places. We protect the data very carefully on servers that, meet all of the requirements of HIPAA or, other rules around the world. And that means sometimes those servers are locked in rooms, disconnected from the internet and, behind physical barriers, as well as a range of other things to keep them safe. And then we have people whose full-time job is to essentially continually internally vet our privacy rules, our data security, and a whole range of other things. We work oftentimes with aggregate data, and that's the last point I'll make. And so while we do work with person-level data quite a bit, we don't only work with person-level data, and so we are able to sometimes answer a lot of the questions we need to answer without having to know, all of the person-level details that you would know from, let's say, microdata about individuals.
So here's a comment. It was notable that earlier during the outbreak, there were daily updates on the data set site. They seem to be less frequent now. Why is that?
Yeah, no, it's a great question. So initially, we actually publicly said we would update it daily. It turned out that we were over ambitious, and we run the model now about 3 times a week. Now, some of what we found is that we needed to throttle back the updates because the data needed to be processed a little bit more slowly because we know that there's some lag in reporting. And we wanted to make sure that for a lot of larger sites, we captured sort of what we knew was going to be a large delivery of data. But on the other hand, we also just discovered what our bandwidth was. And how fast we could run things and how much people could work. So we're still committed to regular updates. Like I said, we should have an update, I believe, later today. It may be online already. I haven't looked yet. But yeah, the place where the rubber meets the road is that we will probably have 1 or 2 updates a week at this point.
And how does precision tweak the remodeling? For example, COVID testing sensitivity is discrete and not 100%. Patient movement is not precise. How do you deal with that?
Yeah, well, there are limitations to all of the data that we get. And one of the things we spend a lot of time thinking about are what are the potential biases in the data. When it comes to the mobility data, we're using very, very large numbers of aggregate, sources. And so partly that gets smoothed out by large numbers, and partly that gets smoothed out by the ensemble modeling approach that we're using to sort of pull different data sources together. When it comes to something like what we know is the very real variation in, let's say, PCR testing at the moment, the answer is that is why our model is built off of death numbers. We still do use data from places where we think a large number of cases have been captured, because we need to know as best we can what the infection fatality rate is. But we've seen a lot of variation in people around PCR testing, probably very, very early in infection when there's not a lot of secretions at the back of the nasopharynx. We may see false negatives. We've also seen people who are positive, then negative, then positive. That probably isn't reinfection. And the antibody testing is grounds for a whole nother lecture. I think there's obviously a lot of variation in those.
Right. And one last question. Any concern about reports of thrombotic events on strokes in recovered COVID-19 patients?
Not that I've seen. I've seen the case series of strokes out of New York and a couple other locations. Again, it looks like thrombosis may be one of the midterm complications, and something that a lot of people are looking for. Pathophysiologically, I think this connection with thrombosis makes a lot of sense, but I think we're going to need larger samples to answer that question for sure.
Okay. And one last comment. Julie says hi.
Hi, Julie.
As a PLME Brown graduate, thank you so very, very, very much for the gift of your time and your knowledge. We all learned a lot, and really appreciate it.
Yeah, I mean, it's my pleasure speaking with all of you. This is obviously, a pandemic that we are all struggling with, and is going to go on for a while. And it's nice to speak to folks back at Brown. It's really been my pleasure.
Okay, great. Well, thank you very much. Wonderful talk. Great.